Am I visible? Rajesh sir, am I visible?
Visible. Just
Yes,
start
we
the
are
slide
visible.
show.
Okay.
Can share the slides.
Yes. So thank you, Rajesh sir, for that kind introduction. Good evening, all. I thank all the organizers for making me a part of this program. So I know putting the 3 guidelines in such a short time, it's a Herculean task. So we'll be attempting only to go to the salient features of these guidelines and how these guidelines came along and why it is important. So today we are celebrating the ISA Platinum Jubilee celebrations. It is happening in Delhi, and let us spread the light spark of ISA in our hearts. So let us go to the guidelines. So this is a glimpse of the Indian guidelines for resuscitation. The guidelines put forward by the Indian Resuscitation Council Federation in 2000. It came out in 2017. So when you see a picture like this, or when you are in a situation like this, so the first question is, are we dealing with a sudden cardiac arrest? If it is a cardiac arrest, what next?
Dr. Brajesh, your slides are not moving, it seems.
Oh. Now what is the situation?
Yeah, it's the first slide has come.
Okay. So we are dealing with the Indian Resuscitation Council Federation guidelines, which came up in 2017. So when you see such a picture, or when you are in such a situation, so how are we going to deal with this thing? Is it a cardiac arrest? And if it's a cardiac arrest, as doctors, what should we do next? So some interesting statistics regarding Indian scenario of cardiac arrest. We know inappropriate and delayed resuscitation may result in adverse outcomes. The mortality in sudden cardiac arrest in India is approximately 4,280 per lakh, in contrast to 60 to 150 in US. And 70% of out-of-hospital cardiac arrest occurs at home. And 90% of the people who suffer out of cardiac arrest die. So how can we save this situation? In one of the newspapers, Times of India, reported in 2016 that 98% of Indians are not trained in cardiopulmonary resuscitation, the basic life-saving technique. So we have got a lot of guidelines, and we have got an International Liaison Committee on Resuscitation, ILCO. But unfortunately, we do not have a representation from India. We never had. It is mainly composed of American Heart Association, European Resuscitation Council, etc. So don't we need our own guidelines? Country-wise, if you look at the population, we represent 17.5% of the world's population as per 2011. So it must be even more now. So we are into the new era of Make in India, and Make in India for the world. So in this situation, we came out with the 2017 Indian CPR Guidelines. So what is so important, what is so peculiar about Indian guidelines? We know Indian population has got its own specialities. It's a large population, and 70% resides in the rural areas with high rate of illiteracy, poor emergency medical services, scarce ambulance services, trained personnel. There is scarcity of automated external defibrillators. Often the guidelines, other guidelines, especially American Heart Association guidelines, everything is more expensive. And moreover, you have got cultural beliefs that people may be hesitant to perform mouth-to-mouth resuscitation like that. And it will be, so the skills are difficult to acquire, and its inappropriate use may do more harm. So our guidelines should somewhat simpler. So Indian Resuscitation Council Federation came up with 3 separate guidelines called COLS, Bcls, and Ccls. So what all they represent, that I have written. So first is meant for lay persons, compression only life support. Then the Bcls, basic cardiopulmonary life support, for trained paramedics and medics when cardiac arrest occurs outside hospital. And for the trained medics and paramedics inside the hospital, you have comprehensive cardiopulmonary life support, CCLs. And I will be going through the first two parts, that is the course as well as Bcls. So in short, these are the three algorithms. So the salient features of IRC guidelines are, they are color coded. Yellow stands for calls, green for Bcls, and blue for CCLs. And the action and outcomes are marked in green and red. And each of these algorithms are standalone, descriptive, and based on available infrastructure. So that available infrastructure is very important in the Indian scenario. So the guidelines are roughly is based on the experience of the rescuer, the place of resuscitation, and availability of facilities. So this resuscitation guidelines, first we will talk about compression only life support course. Course guidelines came 2017, Indian Journal of Anesthesia. So it deals with it is meant for victims with cardiopulmonary arrest in adults. So that is what it is said in the abstract. So CALS is a practical, uniform, and acceptable resuscitation algorithm across India for management of cardiopulmonary arrest in adults. It's a stepwise algorithmic approach for optimal outcome. Avoidance, so it stresses on avoidance of any interruptions of chest compression and relies primarily on chest compression, only CPR by laypersons. So the target group for compression only life support calls is bystanders, the normal bystanders, who do not know CPR well and are reluctant to perform rescue breaths like mouth to mouth. So why calls should be taught? So cardiac arrest in India is approximately 4,280 per 1 lakh, and 70% of out-hospital cardiac arrest occurs in home, and 90% these things I discussed earlier. Every minute's delay in resuscitation of cardiac arrest victim reduces the chance of survival by 7 to 10%. Immediate help is given, is received only by about 46% of people experiencing out-of-hospital cardiac arrest. Survival of victims doubles or triples if CPR is performed immediately by someone nearby. So that is very important. So even if you are the cardiologist or the anesthesiologist, when you have a cardiac arrest, you need someone who knows to give resuscitation nearby. So that can be anybody. So that is the importance of teaching everyone resuscitation measures. So there comes the importance of CALS, compression only life support. So this is the CALS algorithm, the step-by-step approach with compression only life support. So in all the three algorithms, we have got certain core links. In CALS, adult CALS, we have got 3 links. One is the early recognition and activation. The second link is the early chest compression, and the third is the early transfer. Any algorithm for resuscitation starts with ensuring safe place. So you should not start resuscitation in an unsafe place. That doesn't mean that you should not start resuscitation, but instead you should try to take the victim out of the danger and then start resuscitation. Otherwise, if you start in an unsafe place, next victim can be you, and there may not be any person to rescue you. So after ensuring the safety, the next step is check for responsiveness. How you will check for responsiveness? So the tap on shoulder from front and ask loudly. This is very important. From the front, you tap on the shoulder and ask loudly. It is important that the victim should not be shaken nor the next movements done, like tapping on the face. It can aggravate an already existing cervical spine injury. And what it can do, you all know. So you look for a verbal response or a purposeful movement. So two things can happen then when you check for response. Either the patient is responsive or the patient is not responsive. So if the patient responds either by a verbal response or a purposeful movement or is breathing normally, then a cardiopulmonary arrest is unlikely. They can be monitored constantly, shifted to nearby medical facility at the earliest for further evaluation and management. Or till the help arrives, you can keep the patient in the recovery position so that the chances of airway obstruction is least. Please do not turn to the recovery position if you suspect a cervical spine injury, or be careful about it. Then, second possibility is a non-responsive victim. If the victim is non-responsive, you shout for help or call for emergency numbers, including 108. So, when you call for help, what are you going to tell the patient who is taking the phone at the other end? That certain things will help the resuscitation process. So nowadays, everyone has got a mobile and many have got a speakerphone. So you can talk loudly and identify yourself, identify your location, tell about the victim's condition, number of victims, age, sex, complaints, and general condition of the patient or the victims, and the number of rescuers present, so that the persons who are responding can plan themselves and come with adequate resources. So these are the common help numbers in India: 108, 102. Now 112 is India's all-in-one emergency helpline number. And you can also have an emergency trauma care number, or you can have a number of the casualty of the nearby hospital so that they can respond fast. So once you have shouted for help, called for help, you start chest compressions. In fact, if you have got a speakerphone, you can talk on the speakerphone and start chest compression as early as possible. The resuscitation should be initiated as soon as feasible. The main activity of Call's algorithm is effective chest compression, which should be performed continuously till help arrives. So where you should compress the chest. So identification of the position and placement of hands for chest compression. Keep heel of hand, 2 fingers above the xiphoid process. Since this is a medical gathering, I'm not going to explain too much on what is a xiphoid process and all. So it's a lowest end of the breastbone of the sternum. And keep the other heel of the first hand above the first one, as shown in this figure. And interlock the fingers. The elbows are straight. Repeat, elbows are straight. Shoulders above the victim's chest and fingers interlocked, as seen on the figure. What is an effective chest compression? Effective chest compression is pushing at least 5 centimeters, but not more than 6 centimeters. Compression at the speed of 120 times per minute. That is about 2 compressions per second. Not only compression, allowing complete chest recoil between compressions without leaning on the patient, without lifting the hand from the chest, and do not stop chest compressions unnecessarily. So these are the characteristic features of effective chest compression. So you have 30 compressions per cycle, say 1, 2, 3, 4, like 30, and have 5 such cycles of 30 compressions each. Further check for response again. So how will you know that you have reached 30 and 5 such cycles? You count it loudly. It not only helps you, but also the second responder, if there are any, so that they know where you lie. So after 5 cycles of 30 chest compressions, you check for responsiveness again. Then again, 2 possibilities are there. Either now the patient victim has gone responsive, or victim still remains unresponsive. If the victim is unresponsive, you start chest compressions again. You continue. Then that such cycles continue till. So how long, the question is how long to continue CPR? Till medical help arrives, you should continue CPR, calls, chest compression only life support, or till another trained rescuer arrives so that he can take over the proceedings, or victim is revived. There is obvious sign of life. The patient has responded. Or after some time, you yourself will get exhausted. The rescuer is exhausted, or the place suddenly becomes unsafe. There is fire, there is flood, or there is some traffic, things like that. If it becomes unsafe, you should not continue CPR from that point. So when not to start CPR? If the scene is not safe, you should not start CPR. I mean, try to take the victim to a safer place and then try to start CPR. And if the patient is responsive, you need not start CPR. If the victim shows stiff body, like signs of irreversible death, like rigor mortis, so death has occurred a few hours back, there is no point in starting CPR. So calls is done by a lay person who witnessed a victim collapsing or comes across a victim who has collapsed. It is simple, only chest compression, easy to remember and perform even by a minimally trained person. It can even be performed by family members. Easily taught, it can be easily taught and even imparted telephonically. You can guide them telephonically. Remember, in calls, there is no need to check for airway, no need to undress, no need to waste time to check for pulse, no need to observe for breathing. But also remember, calls is for lay persons, not for medics and paramedics. So this is what you have to teach them so that they can teach others and can help when there is a need. And for postgraduates in the studies by IRC, they have found, so there is conventional CPR with control of respiration and all. We will be thinking there has been a study between no flow and low flow. So when there is chest compression, there is low flow. So when you give calls, it increases the outcome by 3 to 5%. It extends the time interval for successful defibrillation. Defibrillation, you know, that is the next step in Bcls. Defibrillation is going to come. So if you give at least chest compressions, so chances of successful defibrillation is more. So when you compare chest compressions only CPR with conventional CPR, so in chest compression calls, there is no unnecessary interruption. So there is no unnecessary complications in CPR training, and it has been found to be effective even when there is hesitation to mouth breathing. And in conventional CPR training, the skill perishes faster because it involves more complicated steps, and practically there are no difference in outcome. So in calls, the steps are less and easy to remember. Calls has been found to, in studies, it has been found to improve the neurological outcomes, improve the coronary blood supply. Interruption with ventilation in conventional CPR results in adverse hemodynamic effects. Interruption with ventilation decreases 48-hour survival even after successful resuscitation, and cardiac arrest for less than 15 minutes. More than 15 minutes, conventional is better, whereas for the less than 15 minutes, calls is been found to be better. So in various randomized controlled trials, it has been shown that compression-only CPR is just as effective as traditional CPR performed by laypersons. So compression-only CPR should be made more public and encouraged, as it can save many lives once the public at large gets involved. The target groups, we said about that, and this is a message. Every citizen, this is what we are aiming at. Every citizen is a lifesaver. All citizens of the world can save a life. So we celebrate 16th October as World Restart a Heart Day. So Indian Resuscitation Council is planning to train calls to 5 lakh countrymen on occasion of World Restart a Heart Day. Previous year, we trained more than 2 lakhs individuals on this day. So as Kalam sir rightly said, problems are common, but attitude makes the difference. So those whom you teach can make the difference in this world. Now coming to the next guideline, that is basic cardiopulmonary life support, BCLS. For trained paramedics and medics, the cardiac arrests are happening outside the hospital. As you can obviously see, it is again color coded. If the coils was color coded yellow, BCLS is color coded green. So CPR by trained personnel outside the hospital. So this is BCLS guide algorithm in short. If you observe a person suddenly collapsing in front of you, or somebody's already collapsed when you saw him or her, or you have arrived at a scene where a lay person is providing CPR, that is course, then you go to BCLS because you are a trained person. You know better than a lay person. Here in adult BCLS, again, this is about adult patients. That is clearly given in the abstract. So it involves 4 links. In calls, we had 3 links. In BCLS, we have 4 links. That is early recognition and activation, early high quality CPR, early defibrillation, and early transfer. So you have got 4 core links. Again, as I mentioned earlier, every resuscitation effort starts with ensuring a safe place. So I'm not going to repeat those things. So many of the things which I said in calls may be a repetition. So I will be just glancing through them. So second step is again checking for responsiveness and tapping on the shoulder from the front and asking loudly, hello, are you all right? So again, do not shake the neck, shake the face, shake the shoulders and all those things. You may be aggravating a already existing spinal cord injury. So 2 possibilities are there. One is the patient is responsive, the victim is responsive. Then you can observe the victim, put the patient in the recovery position if possible and shift to the nearest medical facility. If the victim is non-responsive, again, shout for help, call for the emergency numbers and get AED or defibrillator and emergency equipments. So what are you going to tell them? The same thing which we told earlier. You identify yourself, your location, tell about the victims, numbers, age, sex, conditions, number of rescuers available, all those things, so that the responder can respond appropriately. The basic change when BCLS starts perhaps here. Here, you are trained person. So you have to check breathing, simultaneously palpating for the carotid pulse. In adult BCLS, you palpate the carotid pulse at least 5 seconds, but not more than 10 seconds. Simultaneously check for breathing. You can look, listen, and feel for the breath, while you can stand on one side, slip your 2 fingers in between the trachea and the neck muscles, feel for the carotid pulse, count 1001, 1002, up to 1010. You palpate at least 5 seconds, but never take more than 10 seconds. Time is precious. Okay, so you do it simultaneously. Now, 3 possibilities are there. When you check the breathing and pulse, carotid pulse simultaneously. First possibility is victim is normally breathing with definite carotid pulse. So you can place them in the recovery position, reassess every 2 minutes, and as early as possible, you can shift to the nearest medical facility. See, with having a normal pulse and carotid pulse and a normal breathing doesn't mean that the victim is not having any problems. He may be having a medical problem which need to be treated. So he need to be shifted to the medical facility. Second possibility is an abnormal or no breathing with definite carotid pulse. So circulation part is okay, but respiration part is not okay. In that condition, you provide rescue breath, 1 breath every 5 seconds. That means about 12 breaths per minute, and reassess every 2 minutes. See, now you have got a problematic respiration. After 2 minutes, perhaps he may also have a cardiac arrest. So you have to reassess the patient every 2 minutes. And third possibility is abnormal or no breathing without definite carotid pulse. So there is no respiration or no circulation. In such cases, there is you can say there is complete cardiopulmonary arrest, and you start cycles of 30 chest compressions and 2 rescue breaths. So you said chest compressions, we have already said in compression only life support. We will be talking about that later. So this airway and breathing, perhaps we had not taught the laypersons regarding airway and breathing. So we are trained for that. So previously we used to be taught in resuscitation, it is an A, B, and C, airway, breathing, and circulation. Now, later guidelines after 2011 is taught like C, A, and B. Circulation followed by airway and breathing in adult resuscitation. So what is airway and what is breathing? So, finally, we all want oxygen into our blood, which wants to get circulated and reach the tissues, especially our brain and the heart muscles. So from atmosphere, we are getting oxygen. So we are breathing in the air. So to have that air going into your lungs, you need an open airway. So the path for air is the airway. So it is important to maintain a patent airway. And apart from the patent airway, the breath delivery should happen. Usually we breathe in the air. Here, if there is already a stoppage of breath, you should deliver the breath. So airway has to be kept patent and you have to deliver the breath. How are we going to open up the airway? As anesthesia PG students, you must be knowing the most commonest cause of airway obstruction is colon back tongue. So how are we going to open up the airway? There are certain maneuvers we have learned, like the head tilt, chin lift maneuver. As you can see in the figure, with one hand, gently put on the head, you give the head tilt, and with the other hand, with 2 fingers, you apply the pressure on the chin and lift up the chin. So with this maneuver, you can pull the tongue out of obstructing the airway. But do not do this in a case of suspected cervical spine fracture. So do not do head tilt chin lift maneuver in them. So what are we going to do? In suspected cervical spine fractures, instead of head tilt chin lift maneuver, you give a jaw thrust maneuver. And if another person is available who knows the thing, you can also apply manual spinal motion restriction. And delivery of breath. So you have opened up, using these maneuvers, you have opened up the airways. Now giving delivery to breath. So as school students or college students, we have heard about giving mouth to mouth. So is it the best method? Yes, it is the first method, but not the best. After advent of COVID and such diseases, it is not a very healthy way to have a direct mouth-to-mouth contact. Of course, it can be done, especially if you know the victim, but that is not the best. Mouth-to-mouth respiration with a face shield may be better than a direct contact, as shown in the figure. Or even better may be a mouth-to-mask. A pocket mask is available in the market. You can have one in the pocket in a small box. It is available, and you can blow your exhalation breath into the mask. Or the best method in this situation may be bag and mask if available. The advantage of bag and mask is that it can also deliver at least room air. The other, when you breathe out from your mouth, it is your exhaled air, which contains only 16 to 18% of oxygen. With the use of ambu bag, with your bag, you can have at least the atmospheric air, 21%. And if there is an oxygen source of supply, it can be attached, and you can give even higher percentage of oxygen, which may be beneficial in this situation. Once you use mask, you should know how to use the mask. For an anesthesiologist PG, I need not tell how to hold the mask. So it can be a single hand technique or a 2-hand technique. So a bag and mask device is the preferred device for giving breath when more than one rescuer are present. So how are you going to hold the mask? You can represent by using the term C and E, the C and E technique. A mask has got a broader portion. This is I am explaining because perhaps you may have to teach others. So it has got a broader portion which you hold over the chin and a narrow portion which you hold over the nose. And with the two fingers, one with your thumb and the index finger, you form a C and push the mask onto the face to have a nice airway tight seal. And with the E of the other three fingers, you give apply onto the mandible and keep it tight, as well as keep away the tongue from obstructing the air. So the C and E technique. And you, with the bag and mask ventilation, you give breath like this. You compress and say 1001. So over 1 second, you give the first breath, then release the bag and chant 1002. So that is the exhalation time. And give the second breath over 1 second again, chant 1003. And start chest compressions again. Even in Bcls, even though we talk about airway and breathing, importance is always given for chest compressions. So when there is only respiratory arrest, you can give the rescue breaths once in 5 seconds, that is 12 rescue breaths alone. There you need not give chest compression because there is carotid pulse. So how will you say that your breath has been given successfully? The end point of a successful breath is a visible chest rise. You give only normal tidal volume breath. You need not give high rate, high volume breaths. You give a normal tidal volume breath at a rate of just 12 breaths per minute. Do not interrupt chest compressions unnecessarily. And if the victim starts to breathe normally, you can place the victim in the recovery position. The recovery position you all know as anesthesiology people. I am not going to the details. Now coming to the chest compressions. Chest compressions we have already explained in compression-only life support. So I am repeating those things again. So for giving effective chest compression, the rescuer position is important, identification of the site is important, placement of the hands is important, and process of chest compression is important. For effective chest compression, it is better that you shift the victim to a hard surface, if not already on the hard surface. Like a water bed, your compressions may not be effective. So if possible, it is better to shift the patient to a hard surface like floor, if possible. So you can kneel beside the victim on either side of the patient. Can be on the right side or the left side. The point is the waist of the rescuer should be above the patient. Chest compression identification site. Again, identify the lowest end of the xiphoid process. Keep 2 fingers above the xiphoid process and keep heel of hand above it. And interlock the fingers. These are only repetitions. And elbows straight, shoulders above the victim's chest and fingers interlocked. Compress the chest at least 5 centimeters, but not more than 6 centimeters. Compress chest at speed of 120 times per minute. Allow complete chest recoil between compressions without lifting hand from the chest. And do not stop chest compressions unnecessarily. You can chant the count loudly, 1, 2, 3, 4, like that 30, and continue with those cycles so that if there is a second rescuer, they can keep count of it. And you can interchange. If there is more than one person, you can interchange every 5 cycles. Now, another thing which was not present in compression-only life support calls is presence of defibrillator. To avoid confusion, IRC guidelines talk only about automated external defibrillator. We know these are the 4 rhythms in cardiac arrest: ventricular fibrillation, pulseless VT, pulseless electrical activity, and asystole. And we know in adult cardiac arrest, ventricular fibrillation is the commonest. The good point is that ventricular fibrillation is reversible if treatment is started early. Probability of successful defibrillation diminishes with time. Survival from witnessed ventricular fibrillation sudden cardiac arrest reduces by 7 to 10% per minute if no CPR is done. But it reduces by only 3 to 4% if bystander CPR is done. So the importance of bystander CPR is stressed there also. 90% of patients with primary ventricular fibrillation revert to normal rhythm with defibrillation if done within 1 minute. 90% revert to normal if it is done within 1 minute. So the treatment for defibrillation of ventricular fibrillation is defibrillation. So that is why we use an automated external defibrillator. So in Bcls algorithm, where does a role of AED starts? When you call for help, once you inform the emergency medical system and get an emergency medical equipment, it includes AED. So in some situation, in Indian scenario, sometimes only a manual defibrillator may not only be available, but in algorithm, IRC algorithm, AED is only mentioned because so that confusion is avoided. And even in India, many common public places we are starting to have AEDs. So we should know how to use an AED. We should be able to teach people how to use an AED. High quality CPR should be continued. Chest compression should be continued till defibrillator AED is available. So AED is not available doesn't mean that you cannot do CPR. You continue chest compressions. 30 compressions, 2 rescue breaths. So once the defibrillator comes, what are you supposed to do? You first of all attach the AED. There are 2 paddles and you attach. So the second person who is bringing the AED can attach them. And even while attaching, the first person need not stop giving chest compressions. The second step is important. The AED has to analyze the rhythm of heart. At that point, everyone should be clear. Nobody should touch the victim. And by analyzing the rhythm, do not touch the patient. And AED will tell whether the rhythm is shockable or non-shockable. It will tell. Accordingly, you can act. So if it is shockable, it will tell. It's a shockable rhythm, you give shock. And you can, according to the machine which you are using, you can give 1 shock. So usually AEDs are having biphasic defibrillator, starts with 120 joules and escalate to 200 joules. So all these things, whatever is the shock amount of joules given, you need not count and do the measurements or set the settings. It will automatically do all these things. How much joules should be delivered and all those things. And so when you deliver the shock, as with the normal defibrillator, nobody should touch the patient. Once the shock is delivered, immediately start chest compressions. Do not wait for anything. You start chest compressions and give 5 cycles of 30 chest compressions and 2 rescue breaths. How are we going to use an AED? The step 1, you switch on the AED. Second one, expose the chest and attach the pads. And while doing all these things, do not interrupt the CPR. If there is wetness or more hairs on the chest and if facilities are available, you can remove them so that the contact between the paddles and the chest is better, so that the analysis and the shock delivery is much more effective. So where do we attach the pads? One is the sternal pad, which is placed on the right side of the sternum, just below the clavicle. And the apical paddle is placed on the left mid-axillary line, in the 5th intercostal space, just at the apex of the heart, as you can see in the picture. Step 3 is analyzing the rhythm. Do not touch the patient during this step. Step 4 is that if it is a shockable rhythm, it will tell and it will deliver the shock. When you deliver the shock, make sure no person is in contact with the victim, and a quick visual survey and loudly saying, "I am clear, everyone clear," is important. Post-shock delivery, once the shock is delivered, starts high-quality CPR cycles immediately. 5 cycles of 30 chest compressions, and 2 rescue breaths. Rhythm assessment and early defibrillation done after every 5 sets of CPR. Once AED or defibrillator is available, rather than the pulse check, which is set after cycles of 5 cycles of 30 chest compressions and 2 rescue breaths, rhythm analysis needs to be done. Now we have said about the chest compressions, airway management, and now we will briefly go through how we are going to put all these things together. So one is the single rescuer scenario. There is only one rescuer. So you ensure the safe place, check for responsiveness. There is no response, and you call for help, all the points which you know, and then you check for the carotid pulse and the breathing simultaneously, at least 5 seconds, not more than 10 seconds. 3 scenarios. First scenario, everything is fine. You can put in the recovery position and shift to the medical facility. When there is only respiratory arrest, you can provide rescue breath once in every 5 seconds, 12 rescue breaths per minute. And if there is no breathing without carotid pulse, you start chest compressions 30:2. And repeat, continue for 5 such cycles till defibrillator arrives. Regarding how we give a rescue breath, 1 breath over 1 second and 1 second pause after the first breath. So 3 seconds for giving rescue breath, 2 rescue breaths. So whichever is available, if the bag and mask is available, that may be the best option. But if only one rescuer is there, you can give mouth to mouth or mouth barrier, which is maybe better option. So the end point for a good breath is visible chest rise with a normal tidal volume breath. The quality of chest compressions, all I explained before, so I'm not going to repeat it. And in 2 rescuer CPR, ensuring safe place and check for responsiveness. And if it is not responsive, if there are 2 persons, first person start CPR and the second person go to get AED and emergency equipments. The first person continues with the 30 cycles of 30 chest compressions and 2 rescue breaths. And it is continued till defibrillator or AED is available. And again, the second person will attach the pads and all those things without interrupting the CPR chest compressions. And while analyzing the rhythm, nobody should touch the patient. At this point, the roles are changed while analyzing the rhythm. So the first person will go to the second place and second person will come to the first place and start for the chest compressions. And while delivering shock also, nobody is touching the patient. And the second person now continue with the, after delivery of shock, second person continue with the chest compressions. AED analyze the rhythm after 2 minutes. Roles are changed at this time. So every 2 minutes, AED analysis of rhythm is there. Then at that point, these persons can interchange. 2 rescuer CPR, second person reaches with AED and bag and mask. AED is made ready. Further CPR is as per AED prompts. Ventilation is with bag and mask because the second person has brought the bag and mask. Roles are changed after every 5 cycles of 30:2 chest compression and ventilation, or in 2 minutes. I know very well that many of these things are repetitions, but let things go into your mind. Advantages of 2 rescue CPR is less interruption, better respiration, and switching roles after 5 cycles. So you can do it without exhaustion for much longer time. So this is the Bcls algorithm put together in green. This is available for download in the Indian Resuscitation Council site. So thank you very much. Thank you for patient listening. I know I rushed through many portions, but I couldn't help.
Thank you, Dr. Vijesh. It's a very difficult task to compress Bcls and calls into a 45-minute session, but you have done a wonderful job. And I think it's open for questions. Any questions or any comments? We have senior faculties. Chakrausar is there. Is the father of Indian Resuscitation He's the father figure in the Resuscitation Council. He was the key person responsible for formulating all these guidelines. And it's an honor that we have Chakrarao sir with us. So Chakrarao sir, any comments from you? Chakrarao sir, you have to unmute. It's not unmuted.
You have done a wonderful job in presenting.
Thank you, sir.
The Rajesh, the one point, not for you, for everybody, I wanted to tell you is because we do not have an active emergency medical system where our ambulances does not move. Ambulances may be having a depth of diesel, or the driver will not be in his seat, and it is not. It cannot happen within 3 minutes as it happens in abroad, and we have a different thinking. And whenever there is a cardiac arrest, even in front of us, we will stare at the people and we try to put them on the cot or take them in a auto or car, or otherwise we try to call the doctor, but we never bothered to make a chest compression because we don't know the cause. So that is the one thing which we have to create a lot of awareness. And in 2016, Laborate has made a survey, and they found out less than 2% of the Indians know about CPR. That is true. In such circumstances where the CPR is not taught in our MBBS curriculum or anywhere, now in 2017, the Indian Society of Anesthesiologists has asked me to start one, and I have gathered about 40 people in Hyderabad. And of course, I am not from Hyderabad, I am from near Visakhapatnam. So we have formed a team, and that team has made these guidelines. So there they have realized we don't have AEDs. AEDs, even now, many of the airports have got AEDs. Even 1 or 2 airports do not have because new airports are coming. And another thing, even the hospital corridors do not have an AED or an ambu-bag. Hospitals, OPDs, they do not, because we have very big hospitals with 2,000 beds and 3,000 beds. Whatever that happens, the victim has to rush to the emergency area, which will take more than 10 minutes. So that has to be bear it in mind. And another thing, we do not advise in COLS because it is for the lay people and school children. We are not advising them to see the carotid pulse because even it is difficult for the educated doctors to see the carotid pulse, and probably they may waste the time. Our most important thing is to start the chest compression as early as possible to retain the blood supply to the brain. That is the most important thing. And another thing, and we are not checking the pulse, we are not advising them to check the pulse or the breathing, and we are straight. Of course, if he is an educated or a medic or a paramedic, we train them and with them. And another thing is, of course, definitely it will take more than half an hour for our ambulance to reach because we do not have an ambulance adequacy on the road. Nobody will give way to the ambulance. And by the time it reaches, definitely it will be a brain dead. So we have to start the chest compression. Another thing is the AED part. AED really, even the trainer AEDs are not available now. Even the original, in fact, the AEDs are very expensive. And when we have started, it was sold for 65,000 by Philips. Now they have increased it to 90. And last month they said they don't have because the chip is not coming from Ukraine. I don't know what has happened. So that is the position for AED. And of course, I requested some of the Indian manufacturers. Lubdub has come up with an AED. They have shown me about a week days back when I went to Guntur conference. It is happening. And another thing, what I wanted to tell is, there is not much of a difference in the this one. Our language is very simple, and our manuals are very easy to understand. We have not complicated the issues, and the only thing is we have avoided, for the lay people we have avoided. Now, by virtue of all our efforts, the CBSE has introduced the COLS into the curriculum of 7th class. So it is a wonderful thing, but it is not made it, they have not made it mandatory. And another thing is the NMC has introduced clearly that Bcls and Ccls should be taught in the MBBS. That has come. So one by one, we are trying to move. And the only thing is many people, many of our anesthesiologists and doctors do not understand what is Indian Resuscitation Council, because they don't read. They try to comment only, they don't read. So I request them to read what is there, and all these things, whatever you want, if you want to try a COLS, okay, you try. And some of the presentations which you have shown, we have changed a little, because now we made a federation of the Resuscitation Council, because the ILCAR is asking us to associate with the cardiologists, the emergency medicine people, the physicians, the surgeons, gynecologists, and the pediatricians. So we made all of them as members of the Indian Resuscitation Council Federation. Already the European Resuscitation Council has recommended our plea to admit us in the ILCAR, and like that, even the South African Resuscitation Council has also written to the ILCAR that they should be admitted. Probably the next 15th of November, there is a meeting. Probably we will get a recognition from them. But the problem is the American Heart Association is going to lose a lot of money if they allow us. And another thing, our people always believe the Western world. They don't believe ourselves. That is another thing. So we are doing our best, and whatever the suggestions you give, Dr. Benil is there. Benil is part of one of the scientific committee, and we are again updating the manuals again, and part of it is already written, and it has to be kept for discussion in the next week because of the World Restart a Hard Day and the anesthesia, World Anesthesia Day, where we are diverted like that. But next week we'll be having a meeting with all the stakeholders, and we will talk. Probably many stakeholders, they may participate or not, but our scientific committee with Benil and Vivek Gupta, Rakesh Garg, Rashesh Devan, Baljit Singh, Mukul Kapoor, Deveti and all, they are doing. And not only that, we want new faces to come into the scientific committee and suggest, because we want the message to be spread all over. And another thing, the IMA, Indian Medical Association, has written me a letter appointing me as the chairman of the standing committee of the resuscitation of IMA. So on that basis also, I need 3-4 people from each state to take over this CPR into masses, either through IMA or IRCF, no problem. And we wanted to we have changed the PowerPoints again, because of somebody has objected why there should be a ISA when you are telling that this is the matter of everybody. Then we have made the new PowerPoints also. The new PowerPoints are ready. We can give you for CYLS, no problem. You can teach and you can give the certificates. I'm preparing an app. App will be coming within 15 days. Already I have applied to the BSNL for there is a lot of rules nowadays because of the many issues. So even purchasing the SMS package also, there is a lot of restriction. So I have applied for that, and probably within 15 days we will be having an app. And if they do it through app, of course, there should be one instructor. That instructor will be taking charge of the app, and he can enter the names of those people who have been trained, and he should have at least a mobile number. Of course, even if they don't have a mobile number, probably he can share their mobile number of his family members. So they will be having their own certificate on the app, just like what we get in the vaccination certificate we will be having. We wanted to make first of all, the first responder should be available. The first responder should be available. When there is a problem, definitely the 108 should be able to locate the first responder and tell them. And probably if everything, of course, we don't have a AED now. I'm also telling you, even in the apartments are having 4 floors and 5 floors. And if the victim gets arrested or something happens, it is very difficult to bring them in a small lift. So I am requesting all the smart city municipal commissioners that there should be a lift minimum a dimension of 6 feet, so that a stretcher should be accommodated in the lift. Otherwise, it is very difficult for the victim to be brought down. He will be crumpled and or he will be doubled, and everything will be very difficult. Even by the time he reaches the ground floor, he will be brought dead. So that I am advising. And another thing is, in all the apartments, there should be at least an AED and an amber bag, at least for one of one. All these things we wanted to write to the government, and whether the government will respond or not, we're all good soldiers of the program. Let us try more and try to get something at least. So this is my opinion. Definitely, you give us suggestions. We'll try to get them. Actually, the government of India, the transport ministry has called us for a talk to train everybody on the highway because they have some something like these things on the highway. They wanted to train us, and even yesterday, Raipur Vidhan Sabha has asked some of our people to train their people for CPR. Yesterday, she went and given an introductory lecture, and I think there are about 400 people in the Vidhan Sabha, and she will be training them one by one. 30 a batch she wanted to take, and she will be training. So like that, definitely. One thing is, why we are called is we are not asking for money, and all of our people are really sweating and taking their time. But I tell them, whenever there is a possibility, you charge, even for CYLS, because it is becoming difficult for the mannequins to get them ready. And sometimes we have to give them some fruit juice or something like a samosa. All these things are being expensive. So we need some sponsors for all these things. Definitely we will do it. And nowadays, till now, our people are not charging any remuneration, but some people are asking for remuneration. We should be able to give the remuneration. And I tell you, it is not supported by Government of India or anything. It is actually supported by the Andhra Pradesh Medical University, and all of them meticulously, their house agents, compulsorily they are trying. Actually, I went and talked to the Kerala University also. He has appreciated, but he has not given a good answer, but I am writing in again. So definitely, if the universities, at least the house agents get trained with about 550 rupees manual and certificate, definitely we can do a wonderful thing. We can save a lot, because we are not taking any salaries, or we are not spending anything out of that. But we need a lot of money for the development of software and the apps and all these things. And part of the money is actually borne by my friends from US, and they are paying. But one person has asked, how much you pay me if I train 20 people for COLS? Then I said, how can I pay you? No, you should pay me at least 2,000 rupees if I train to 20 COLS people. One person has asked. He's from US actually. I didn't answer them because I don't want to. This is the thing. Thank you very much.
Thank you, sir.
You have nicely covered the entire topic.
Thank you, sir, for your kind words, and congratulations for your excellent efforts, sir. Thank you very much. And any more questions? In the chat box, there is no questions. So if you got any queries, you can unmute and ask now.
I don't think there is any questions in the chat box.
So if there is no more questions, thank you, Dr. Rajesh, for the excellent session. And Dr. Brijesh presented very well. Congratulations,
Very well,
Brijesh, and thank you. And now we got our second topic, that is pearls of comprehensive cardiac life support. It will be presented by Dr. Vijesh Venugopal. He is basically a cardiac anesthesiologist. He's a professor and HOD of Department of Anesthesia, KMCT Medical College, Mukkam, Calicut. Over to Dr. Vijesh. He got vast experience in cardiac anesthesia. He's at present he is our GC member for ISA Kerala State Chapter, and he is the past academic coordinator of ISA Kerala State Chapter. Dr. Vijesh, please.
Thank you, Dr. Binesh. Slide is visible.
Yeah, slides are visible. Please start the slide share. I mean, slideshow.
Yeah, this is in slideshow now.
No, it didn't start till now. I think I'll just stop your this thing.
Yeah, fine.
Let's share once more.
Yeah, sure.
Still the blinking is there, Vijesh.
I don't know. Okay.
It's coming now. Yeah, now it's okay.
So thank you, Dr. Binesh, for that kind introduction. And we move on to the IRCF guidelines of showing an overview of CCLS. It's comprehensive cardiac life support. And this is actually a 2-day program, and we are trying to compress this into the next 20 to 30 minutes. So the optimal outcome of a patient after cardiac arrest inside the hospital depends not only on the basic resuscitation steps, which has been already described by Dr. Brijesh, but also we have to incorporate some advanced steps which includes administration of drugs, airway management, correction of underlying etiologies, advanced monitoring, and post-resuscitation care. The comprehensive cardiac life support is a stepwise algorithmic approach to manage a patient with cardiopulmonary arrest inside the hospital. Now, it's designed for trained personnel with adequate skill and knowledge who have basic infrastructure and support available. Now, if you look at the algorithm, it is sequential. So these steps, however, these steps can be done simultaneously when more than one trained personnel is available. However, we should follow the ethos of the algorithm. The division of work needs to be done in such a way that the patient gets care at the earliest while all steps are being followed. If you look at the core links in the adult CCLS program, it consists of mainly 5 core links. And if these core links are done properly, then definitely you will have a successful CPR. So coming to the first core link, it is early recognition and management of the pre-arrest condition. Now, the prevention of cardiac arrest should be a priority in patients who are admitted in the hospital. The cardiac arrest is usually preceded by deterioration in physiological instability, including abnormal vital signs, such as tachypnea, tachycardia, and hypotension. So these pre-arrest conditions should be identified and timely corrective measures should be initiated. So we should develop strategies for early recognition of high-risk patients and manage the underlying etiology, and thereby we prevent a cardiac arrest occurring. Now, in case cardiac arrest does occur, there should be an early recognition and activation of the code blue system. So a system should be in place for the prompt activation of a resuscitation team along with the crash cart, which includes drugs, airway equipment, and defibrillator to be brought to the site of cardiac arrest at the earliest. Call for help from the hospital teams, which may be code blue, or in some hospitals, we can have the intensive care unit people running over to the site where the cardiac arrest has occurred. So it depends on the place where you're working. The third link is early high quality CPR. So this is what we stress upon in the CCLS guidelines. We should give high quality CPR, and I will discuss this later in the talk. The next thing is early defibrillation. So we should get a defibrillator to the site at the earliest. And what does a defibrillator do? It converts a shockable rhythm to a perfusing rhythm. And the final one is early comprehensive life support and post-resuscitation care. So these are the 5 core links that are going to help us in giving a successful CPR to our patients. Now, these guidelines were published in the Indian Journal of Anesthesia in 2017 by Dr. Rakesh Garg, Dr. Ahmed, Dr. MC Kapoor, Dr. Chakra Rao, Dr. Mishra, Venkatagiri, and Dr. Baljit Singh and Dr. Divatia. And this is how the algorithm looks like, and it is color coded in blue. So the first step is to ensure a safe place. So mostly in the hospitals, most of the places are usually safe, and you can do the CPR in that same place. But however, we ensure that it should be safe. And following this, what should be done is you should check the response by tapping on the shoulder. Don't shake the patient, but tap on the shoulder and talk to the patient loudly and ask him whether he is all right. And it should be done in the language, in the local language. And obviously, when you do that, you have 2 responses. Either the patient could be responsive or he could be non-responsive. And if the patient is responsive, that means he had a small problem. So we should monitor the patient and assess the cause and manage accordingly. Now, suppose the patient was unresponsive. You have to activate the code blue team and ask for help. And once that is done, the person who is the first responder, he can check breathing while palpating the carotid pulse. And we should do that within 10 seconds as was described by Dr. Brijesh. So you can assess for both pulse and breathing in one single go. And then you can, once you check the pulse and breathing, you can have 3 responses. The first thing is you could have a normal breathing with a definite carotid pulse. In such patients, you can move them to the high dependency unit and reassess every 2 minutes and assess the cause and manage accordingly. The second response is you could have a definite carotid pulse, but the breathing would be abnormal. In such cases, you have to provide 1 breath every 5 seconds using a bag mask. And You reassess every 2 minutes and assess the cause and manage. The third scenario is where there is no breathing and no definite carotid pulse. In such cases, we move on to giving 30 chest compressions and 2 breaths. So you give 5 cycles of 30 chest compressions and 2 breaths. So 30 compressions and followed by 2 breaths. Each breath is done over 1 second. All this has been already covered in the Bcls lecture. And at the end of 5 cycles, you again check for carotid pulse. So checking for carotid pulse should be done within 5 to 10 seconds. So we wouldn't like to interrupt chest compressions for anything that is more than 10 seconds. So it should be done in less than 10 seconds. Now, if pulse is present in such a scenario, then if only breathing is absent, then you can just provide bag mask ventilation. And if in case pulse is absent, we continue the 5 cycles till we get a defibrillator available. And once the defibrillator is available, we attach either the leads, the ECG leads, or we can keep the paddles and look at the rhythm. So while attaching the pads, you don't stop chest compression, and while analyzing the rhythm, we don't touch the patient, and we see whether the rhythm is shockable or non-shockable. Suppose the rhythm is non-shockable, we don't give any shock and we continue CPR. However, if you have an assist tool, always make sure that all the leads are connected properly. There is no disconnection of the leads, or whether you should look at the gain of the ECG that is there on the monitor. On the defibrillator, probably you have to distinguish between whether it's a fine fibrillation or an asystole. So look at the gain settings and look at whether there is any break in the leads before we say that this is a non-shockable rhythm. Now, coming to the shockable rhythms, in shockable rhythm, you start defibrillation with, if it's a biphasic, you give 120 joules and escalate it to 200 joules. So always give 5 cycles of 30 compressions and 2 breaths. And simultaneously, during cycles of CPR, we should ensure that we obtain venous access, airway, and provide drugs. Antiarrhythmics can also be given, and also look for reversible causes. Always we ensure high quality CPR. That is, after a definitive airway, we continue compression at 120 compressions per minute and give 1 breath every 6 seconds. Now, coming to the airway management, it is essential that chest compressions should either not be interrupted at all, or it can be interrupted for a maximum of 10 seconds for airway management. The healthcare profession should be well versed with basic airway management, as it is crucial for maintaining airway patency and providing breaths. So already the basic airway management has been shown. It consists of basically manual relief of the upper airway obstruction by doing either the triple airway maneuver or giving bag mask ventilation or the insertion of oropharyngeal or nasopharyngeal airway. And in case you suspect a C-spine, you don't go for a triple airway maneuver, but you go in for a chin lift or a jaw. You don't or go for a jaw thrust. So in advanced airway management, it can be done either by using an endotracheal tube or a supraglottic airway device. The correct placement of the ET tube or the device should be ascertained using clinical signs such as bilateral chest expansion and 5-point auscultation and a waveform capnography. The rescuer should ask for momentary interruption of chest compressions to facilitate tracheal intubation only if absolutely required, and such interruptions should not exceed 10 seconds. A video laryngoscope, if available, may be used for better success rate and reduction in complications during advanced airway management. Now, what are the goals of advanced airway management? It is for control of oxygenation and ventilation, for airway protection from aspiration of vomitus, secretions, blood, or gastric contents, and it reduces the hands-off time during CPR. The 30:2 synchronization is not required once the advanced airway is in place. So the chest compressions are continued at 120 compressions per minute, and 1 breath is given every 6 seconds. So now coming to a concept of chest compression fraction. The proportion of CPR time spent providing chest compressions is referred to as the chest compression fraction, and studies have shown that the CCF should be above 0.6 to ensure the probability of a successful CPR. Now coming to the next aspect of CCLS is obtaining vascular access. The most preferred vascular access is a peripheral venous access. So in case the venous access is not secured in initial 3 attempts, then the second choice remains an intraosseous cannulation. And it can be done using the intraosseous needles or by a mechanical battery operated device. And what are the sites where we usually obtain this is usually in the proximal tibia, that is 2 to 3 centimeters on the anteromedial surface below the tibial tubercle, or in the distal femur, that is 2 to 3 centimeters above the lateral condyle, or it could be above the medial malleolus, 2 centimeters above the medial malleolus. So these are the most common sites. The other sites that can be used are the sternum or the upper humerus. And you have different color-coded intraosseous needles. The pediatric one is pink, the adult one is blue, and while in little obese patients, you can use the longer yellow-colored intraosseous needle. So the indications are for difficult or failed intravenous access, for life-threatening emergency situation, in obese patients with limited vascular access, or in a pre-hospital care in moving ambulance. Now, suppose you don't get both the intravenous or the peripheral venous access, intraosseous as well as the intravenous access, then in such cases, drugs may be administered through the endotracheal route if the patient has already been intubated. Now, these drugs include naloxone, epinephrine, atropine, and lidocaine. The intratracheal dose should be 2 to 2.5 times that of the intravenous dose, and it should be always diluted to 10 ml. So what are the drugs that we commonly use during the comprehensive cardiac life support? The most common drug that we all use is epinephrine. The other drugs that can be used are noradrenaline, atropine, the antiarrhythmics like amiodarone, lignocaine, adenosine, magnesium. So coming to adrenaline, adrenaline is the one drug that we all commonly use, and it is repeated every 3 to 5 minutes, 1 milligram, which is diluted in 10 ml and then given to the patient. So how do you administer these drugs? Now, drugs should be administered during chest compression so as to ensure their systemic distribution. You can give drugs either in the bolus dose or as a continuous infusion. Bolus the drug should always be diluted in 10 ml of normal saline. It should be followed by a 20 ml saline flush, and we should raise the limb for 10 to 20 seconds so that it gets into the circulation. And during this time, we should not interrupt the cardiac compressions. Next step is to assess and manage the reversible causes. There are certain causes of cardiac arrest which are potentially reversible, and it's imperative that we look at these causes and find them out. So the CCLS expert panel have given us a mnemonic to remember the causes and which can be assessed and managed. The mnemonic is hit the target. So each alphabet is a clinical condition which can be assessed and treated. So hit the target: H for hypoxia, I for increased hydrogen ions, which indicates acidosis, T for tension pneumothorax, T for toxins, the next H for hypovolemia, E for electrolyte imbalance, which could be hypokalemia or hyperkalemia, T for tamponade, cardiac tamponade, A for acute coronary syndrome, R for raised intracranial pressure, G for glucose levels, it could be hypo or hyperglycemia, commonly hypoglycemia, E for embolism, that is the pulmonary embolism, and T for a temperature drop, that is hypothermia. So these are the conditions which can potentially cause cardiac arrest, and this should be, we should always see whether these patients have this and these are reversible. So potentially we can prevent cardiac arrest from occurring. So once the patient is revived with signs of circulation, we should provide them with post-resuscitation care. So what does this post-resuscitation care? Now, these patients, once they have been revived from cardiac arrest, they should be shifted to a monitored area, and further definitive treatment of the underlying cause should be started. Now, since cardiac cause is the most common one, we should always have a consultation for a coronary intervention. So a cardiac consultation, or cardiology consultation should be done if we suspect that this patient had developed a cardiac arrest because of a coronary occlusion. Now, CPR may lead to hypoxic insult to various organ systems, including brain. So oxygen supplementation and ventilation support should be provided based on the post-resuscitation assessment of the patient. Hemodynamic monitoring is essential during the post-resuscitation phase, and we should try to maintain the mean arterial blood pressure around more than 65 millimeters of mercury. So at present, controlled hypothermic equipment is not available in India easily. So the need for hypothermia should be assessed if necessary, and if equipment is available, we can proceed, but otherwise it should not be done. However, active warming should not be started for patients in the post-resuscitation care. Now, how long do you continue CPR? CPR discontinuation should be based on clinical condition of the patient. So it may be suggested that with high quality CPR, once you ensure that your CPR quality is high, and if still you have a rhythm which is asystole for more than 20 minutes, if you see that your EtCO2 is less than 10 millimeter mercury, these are signs to forego further resuscitation. So if you have a rhythm, asystole rhythm for more than 20 minutes, or an EtCO2 that is less than 10, once you have ensured that you have given high quality CPR, still these two things are there, then you can discontinue resuscitation. In patients without such monitoring, a definite time frame has not been suggested, and duration should be based on your clinical decision. A very important aspect of getting a successful CPR outcome is the team dynamics. We should have good teamwork. So every alphabet in the word team, that is together everyone achieves more. So you should always work as a team. We should have good communication skills as well as good clinical skills. And we have a team should be ideally of 6 members, including a team leader and 5 team members. So one person is in charge of the airway. The other is in charge of the chest compressions. Another person is in charge of venous access and medications. Another person in charge of the defibrillator and the monitor. And the 5th person in charge of, he's in charge of recording the drugs that are given and the rhythm that is there. So he records the timing and makes a record of all the drugs that are being infused. And finally, we have the team leader. So the core concepts of team dynamics is that you should have specific task assignments with understanding the team member's strength and weakness. So the team leader should give specific tasks. She should assign that one person is in charge of airway, so he does that. And he should recognize that there are certain people who are good at certain things, so he should assign them to that task. We should avoid crosstalk while there is CPR is going on, and we should follow closed loop communication. Closed loop communication means that once the team leader says give 1 milligram adrenaline, the person who gives the adrenaline communicates back that I am giving 1 milligram adrenaline. So there is a closed loop communication so that no mistakes are done. Similarly, clear and directed delegation of messages should be there. Constructive input should be given. Every member should give constructive input. Suppose one of the member feels that something is going wrong, he should raise that point to the team leader and a constructive input can be given. However, there should be mutual respect for the team members, and only in such cases this constructive inputs will work. And finally, after the CPR, debriefing should be done where we can find out whether anything we have done is wrong or not, or what are the steps we can take for improving the CPR performance. Now coming to the very important thing, that is quality assurance of Ccls. One of the core links is to give high quality CPR. Now high quality CPR, 2 aspects are there. One is on chest compressions, the other is on the airway. Coming to the chest compression, very important that chest compression speed, rate and recoil, it should be fixed. So we should ensure that chest compression speed of 120 compressions per minute to a depth of 5 to 6 centimeters should be ensured. We should allow complete chest recoil between compressions without lifting the hands from the chest. And we should not lean on the patient's chest. and we should not stop chest compressions unnecessarily. So these are the three very important points that we should follow to assure that we are giving high quality chest compressions. Now, looking at the ventilation in the airway, we do not unnecessarily interrupt chest compression for securing the airway. Do not hyperventilate. End point for ventilation is visible chest rise after a normal tidal volume breath. And we should, if possible, monitor end tidal capnography. If it is less than 10 millimeter mercury, then the CPR quality is inadequate and it needs improvement. So we should make sure that we have a ETCO2 that is more than 10 when we give whether our chest compressions are adequate is we can monitor it by using the ETCO2. If you have an intra-arterial pressure monitoring, if it is available, then the relaxation phase, that is the diastolic pressure, if it is less than 20 millimeters of mercury, it indicates inadequate chest compression, and we have to improve the chest compressions. So we have two monitoring devices, that is the ETCO2 less than 10 and a diastolic blood pressure is less than 20. That is an intra-arterial diastolic blood pressure that is less than 20. These two indicate that our quality of CPR is inadequate and we should improve it. So I would like to conclude by saying that the management of cardiopulmonary arrest inside the hospital requires early recognition along with early high quality resuscitation, including defibrillation. Following the core links, that is the 5 core links that I had shown before in adult resuscitation, would improve the overall outcome. Ccls emphasizes providing high quality resuscitation. Simultaneously, we should look for cause of cardiac arrest and correcting the reversible cause while continuing resuscitation. Thank you.
Thank you, Dr. Vijesh. It was an excellent presentation. And now I welcome the questions from the audience. I appreciate the presence of Dr. P. Shashidharan, our senior past president and senior member of IRCF Kerala State Chapter.
There he is. I am not able to see him.
And
one
also
thing I would like to say is the nomenclature in Indian Resuscitation Guidelines is changed from the American Heart Association because of the fear that the copyright issues. Even when we are presenting this, they have asked for our manuals. They have verified for the plagiarism, and they did many things to stop us. And that's why we don't call the chain of survival. We say that core links, and we never say that push hard, push fast, and push hard.